All right, so we'll go ahead and get started. Welcome everybody back from the holiday break to UCSF's Cardiology Grand Rounds. I'm honored to be able to present today Dr. Bill Lombardi, who will be speaking to us on the effect of competencies on patient care and clinical trial outcomes. Dr. Lombardi completed his training at the University of Utah, Salt Lake City. He completed fellowships in general cardiology, heart failure transplant, and interventional cardiology. He then returned to his home state of Washington to work at St. Joseph's Hospital in the city of Bellingham, where he developed novel techniques and technologies that are now at the core of contemporary treatment for chronic total occlusions, or CTOs. In 2014, he joined the University of Washington Medical Center, where he currently is a clinical professor of medicine and director of the Complex Coronary Disease Therapies program. And with that, welcome, Dr. Lombardi. I'm excited to hear the talk. If anyone has questions over the course of the talk, please type them into the chat box, or if you prefer to keep them anonymous, you can also direct message them to me and I can ask them on your behalf at the very end. Thanks so much, Dr. Lombardi.
Oh, well, thanks for having me. I'm glad to be here. Hopefully we can stimulate some emotion or some discussion here in the next hour. So I'm going to talk about something that is really a challenging topic to have with our profession, which is really talking about competency and techniques and how those really affect what we're doing and moving forward in our profession. So I'm going to start, hopefully. Oh, that's interesting. There we go. There's all of my conflicts. I'm a very conflicted person, but I hopefully am so conflicted it actually ends up being equal. So I'll also continue with my disclosures, which is I'm not here to talk about bypass surgery versus intervention. Okay. I also would tell you is I think the real issue, and we'll talk about this, is why interventionalists is we're not very good. And we just need to look at the data and we need to look at ourselves in the mirror as to why we're better. And then we want to talk about what happens if CABG isn't an option. And then the last is, are medicines really better than revascularization, or are they just a dumping ground for what we can't do? So I want to start with care variability. So everybody, and I don't know how many people are online, but we'll just say everybody that's online, this is easier when it's in person, by the way. Do you know which hospital that you'll be going to when EMS takes you for your STEMI? And if you do you know all of the interventional cardiologists at that institution? And lastly is, do you know which one is the worst interventional cardiologist? And is that person good enough to treat you or your partner? And the reason I bring that up, I have a good friend of mine from the Midwest who had an anterior wall STEMI, and he had to go to his own hospital where he works and have his partners treat him. And the person on call did not know how to do radial access and had never done radial access, right? It's only about 35% of the cases in the US get radial access. So, and we know if there's any benefit to radial, it's in STEMI, okay? So now he's gonna have to get femoral. Okay, that's all right. So we also know that if you do image-guided PCI, the outcomes are dramatically better, except the person doing the procedure doesn't know how to read IVUS. So this 61-year-old interventionalist has to get a femoral procedure, take no conscious sedation, interpret his own IVUS to get an appropriately sized stent during his STEMI. And most people in the room, if I'm in person, people laugh and chuckle and think that's kind of funny. Is it? Or are we just we're emoting that it feels funny, but it really is horrible. If that were me, it'd be awful. I get in trouble because I know the hospital that I'm supposed to go to, and my family and everybody knows not to let me go there. I want the ambulance to drive further away because I would never let any of those people touch me because they're not competent in a way that I think is reasonable and rational. So another piece in this is a little bit of the arrogance of our profession, which is we tend to at times take can't for shouldn't. And again, I'll start with a story of another patient, a 54-year-old gentleman who had a bare metal stent of his OM at age 44. That stent occluded. He went to bypass surgery the following year, got a Lima to the LAD and 2 vein grafts. At age 51, both grafts were occluded. He went to his board-certified interventional cardiologist, and this is in the last 8 years, and his board-certified interventional cardiologist said, you should get a redo 2 vein graft bypass surgery. Now, that's an interesting choice, but okay. And unfortunately, after a year, both of his grafts are occluded. All right. So He now has class 3 angina. He's on 3 drugs. He can't work at 51, can't run around with his kids. He has a high-risk nuclear stress test. His board-certified interventional cardiologist told him there are no treatment options. There is nothing we can do for you. Now, I will add into this, that is someone who is actively stupid. Because if I'm a patient, I can get on the internet and find out you just told me a lie. So don't be that. Don't tell patients things that are not true, because if I can get on Google and find out you're not being honest, we need to discuss can't. And so really the question is, are there options? And for the interventionalists in the room, and maybe even for the general cardiologist, do you need to look at the pictures to decide whether this can be fixed or not? Because I would tell you, in my world, an interventional cardiologist shouldn't need to look at the pictures to know whether they can or can't. This patient on the appropriate use criteria is green. This patient has had 2 bypass surgeries because he's appropriate for treatment. Okay? So I'll show you the pictures. So here you go. There is his circ stent that's occluded with a long CTO and a collateralized OM. And there is his PDA. You can actually see the graft at the bottom of it. Okay. So now if I pull the room, guess what I'm going to get? I'm going to get a bell-shaped curve. So should we send him to the Cleveland Clinic for a 3rd cabbage? Should we hope and poke and we'll just fix the circ? And if we get it, we get it. Should we use ranolazine that makes people walk 42 seconds longer on a submax Bruce protocol treadmill? We've been talking about stem cells since I was a fellow 20 years ago, and it was 5 years away 20 years ago, and it sounds like it's still 5 years away. We could do EECP, the geezer squeezer. You can tell your 51-year-old, take disability, you can't work, good luck with your kids. Or can he get treated? Okay, so he chose to get treated. So that was his circ. That was pretty easy. We just wired it, stented it. And then the lima is actually, the LAD is open, so we used it to go down his LAD, get in a collateral. This is called a retrograde procedure, if you haven't seen it. We're actually taking a wire across the septal into the PDA. And then we ended up doing a late culotte and kissed it out. And he had complete revasc. And his angina went away. He backed down just to secondary prevention therapies. He went back to work and he's taking care of his kids. So when you think about those stories of the interventionalist who had to do his own IVUS, and you think about a patient who was told there's no options, are we really being honest about those things? And part of this is the culture of medicine. So I put up a list of a lot of interesting things, right? Now, all of you in the room, you're at a very prolific academic center who's, had, Eric Topol went there and Bob Califf went there and, lots of people. One of my partners, Jamie McCabe, went there. But how come the first people who did bypass surgery were not embraced as innovators and they're changing healthcare and they're making it better? They were ostracized. When Andreas Grunzig did the first PCI, he was laughed at. I trained at the University of Utah during the era where beta blockers were being developed for heart failure. And I will tell you, my colleagues and my mentors were laughed at and made fun of until they were brilliant. So when you see new things coming out in healthcare, are you likely to adopt, innovate, and support those people and say, we're going to learn to do this? That means some bad things are going to happen along the way because that happens. But we know that if we continue to learn from our failures and learn from complications, that we'll get better and we'll be able to offer things that other people are. The other is, if we learn to do it, we can speak from strength if we think it shouldn't be done. Otherwise, I'm going to say, don't do it because I don't know how to do it and I don't want to be vulnerable that I need to learn it. So is there an attitude or culture change that we need across the profession that instead of always saying, don't do that, actually embraces the young generation, embraces the innovators, and says, let's all help move forward? And that brings me to something, at least for the procedural people. It's a little harder for some of the non-procedural people, but I'll lay this out. If I take a group of 1,000 interventional cardiologists or 100 interventional cardiologists or 110 interventional cardiologists, there is a bottom quartile and a top quartile. And their real abilities is aligned. Now, You hope that the bell-shaped curve of that's really tight, but it's not. We know the bell-shaped curve of intervention is like this. And the real challenge is those who are the worst have the biggest gap in how good they think they are. And actually, those who usually are best don't think they're as good as they actually are. Now, that's interesting, and you can say, wow, whatever. But the real point of this is, who would you trust to tell you where you are on that curve? Would you go to a sycophant who would tell you, well, clearly you're in the top 25% and you're great and everything's awesome, right? Or would you go to somebody who could honestly critique and say, you know, you're pretty good, but you're not that good. You need these things to work on to get better. You need to be coached. And it doesn't matter if you're a fellow or you're the most famous person in your program. Every one of us needs to look in the mirror every year and go, am I as good as I think I am? And who coaches me to get better? And I have people I work with that are my coaches to make sure that I keep technically improving, that clinically I improve, and professionally I improve as a mentor, so that I don't fall into a gap where I think I'm great when I'm really not. But that also means having to be really vulnerable, because it hurts. It's terrible to have people tell you you're not very good. It hurts to fail cases. It hurts to have complications. And that leads to something called the Dunningkruger effect. So when you innovate, when you do something new, whoever's doing it, or when you learn something new, you have the highest level of confidence that you're going to pull it off. Unfortunately, as you gain experience, your confidence starts to go down. And in the bottom of this curve is called the valley of despair. And the reason you hit the valley of despair is because what you realize is this is really hard and it's really tough. And in medicine, most people get to the valley of despair and they're tired of M&M. They're tired of a bunch of people who don't really know what they're talking about, tell them they shouldn't do it. They can't deal emotionally with the fact that they're not great. They emotionally can't deal with the fact that people are getting hurt in front of them. And so they never gain expertise, because the culture doesn't sit there and say, I love you, I care about you, I want to help you get better. We point fingers. So to become an expert is a really challenging process in healthcare, because we lack the mentorship to promote people learning new things, and we lack the ability to help those achieve their best. And their best might be better than you. And that's actually what you want as a teacher. You want your students to be greater than you. But to do that, you've got to give away all the secrets. You've got to support them when it's troubling and help them grow. And so as we think about all of these challenges to getting better and to learning, and we think about competencies, how is that going to affect the outcomes of trials, right? Because we're a medicine specialty, right? So I'm going to do a double-blind placebo-controlled trial. I'm going to give you a pill and a pill. Well, giving a pill and a pill takes the exact same skill. Doing a PCI and doing a PCI, or doing a TAVR and doing a TAVR, takes different skills, because they're not all the same. And that's going to affect who we put in a trial, and it may affect the outcome of the trial. And I'll show that in a couple of interesting ways. A lot of therapy trials that are outside of medications are run as intention to treat. So in Stitch, it took 10 years in intention to treat to show that surgery was better than just medicines alone to improve survival in people with ischemic cardiomyopathy. What's interesting is, if you look, I don't know if you can see my arrow, but if you look at this, the two blue are not intention to treat. It's they got medical therapy. The red and the green are people who actually got surgery. And 4% of people in the medical arm got a CABG. That seems weird. And 4% of people who were supposed to get a CABG got medication. So if I look at the therapy, so not that I hand you the pill, that I hand you the pill, I look at the therapy that you got. Surgery actually at 5 years has a mortality benefit. So we affected the outcome simply by the trial design, and because we didn't follow the trial, which is to give people the therapy they were assigned for whatever potential bias or reason that occurred. Now, the second piece is an interesting slide, and this is important to think about. This is actually the syntax trial, and syntax was a trial of PCI versus CABG, okay? And in the trial, it basically said is the higher your syntax score, the more disease you have, surgery is going to be a better option for you long-term, okay? What's interesting is if I look at centers over here, all right, and I did the trial just in these centers, surgery is going to crush PCI, okay? But if I had done the trial in these centers, stents would have crushed surgery. So the real question is, are stents better than surgery or surgery better than stents? Or it really is the operators in this center are better than the operators at that center. And so it really depends on which center you go to is whether surgery or PCI is better, because it depends on the skill of the operator. And is the operator's skill set affecting the outcome of the trial? And this leads to something called differential skill sets. My father was a commercial airline pilot, which is why I'm a big believer in competencies and case discussion and reviewing failure and accepting failure and sharing and learning from failure, because that's why there are so few airline crashes. So my dad actually flew the plane in the center. That's a DC-10. It's a commercial airliner. Most interventional cardiologists fly this. It's a nice, simple, easy type A lesion. A lot less do this. This is a sort of simple distal left main bifurcation. Even fewer can do a surgical turn down EF20 with a double CTO, which is like landing on an aircraft carrier. Now, my dad had 34,000 hours of flying time. He got to go up to the Naval Air Station with a buddy of his and fly the full motion sims to land on an aircraft carrier. 34,000 hours, commercial pilot, very, very good at his job. He hit the deck once. He never kept the plane intact in 2 hours. Could my dad learn to do that? Sure. But to do that, he would have to go back and be retrained. So it was incredibly humbling that he wasn't good enough. But it's also, are you a person of, well, I can't do that, they're just better than me? Or are you a person who goes, how did they learn to do that? And how do I get that education and develop that skill set? And how do I keep getting better so that I can do that? Now, we could talk about public reporting as a way to help people, and I'll just simply say that public reporting harms patients. And my values are very patient-focused. I believe in patients, and I believe in educating physicians. And this is data from New York, Massachusetts, and the surrounding states. And what this says, if you happen to be on vacation and you are in New York or you are in Massachusetts and you start getting chest pain, get in a car and drive across the border to one of the non-reporting states. Because in the reporting states, you are less likely to get a PCI. And because of that, you are more likely to die. Because healthcare is a fear-mongering. Don't do that. Something bad might happen. Don't do that. Something bad might happen. Don't do that because I don't do it. Right? The number one reason we send people to bypass surgery, which has a far higher mortality than PCI, is simply because we want to defer the risk to someone else, and because it's too hard for us, and anything that's hard for us, we're going to give to somebody else to deal with because we don't want to look in the mirror and say we can't do it. Now, that's led to a lot of problems in our profession. We talked a lot when I was in practice and developing is, well, we needed access to care. Well, we have to have a program for access to care. So from 2004 to current, we have doubled the number of interventional centers in the United States. There are more than 2,200 interventional programs in the US, and it's getting worse with the outpatient-based or ambulatory surgical center stuff. We have increased 1.8% the population that's covered. So we didn't actually improve care. We actually just diluted expertise and diluted resources. And where did most programs show up? Shockingly, it was about money. Shockingly, it was about ego and opportunity for people to develop. Kind of unfortunate. And if you were a patient, would you go to a center without surgery on site? Would you go to an operator that does 33 PCIs per year on average? Right? I mean, I've got involved in the medical legal environment for, and there are experts, quote unquote, of intervention who have been deposed more than they've done interventions in the last 5 years, but continue to go out and pretend to be an expert. But they're not, because they're not doing the job. And they were never expert to begin with, because the minimum competency to do our job is basically you graduated a fellowship. And even of the interventional fellowships, do you know what the competency levels of the faculty are? 0. Nobody's held accountable to being good. Unfortunately, that affects the outcomes of people. That people who do the job at a higher rate tend to do it better. Now, there's other pieces that go into that. And again, I could make an argument that, great, you did 500 PCIs as a fellow, that helps. But if you don't know how to put a guide extension in the PDA, if you don't feel comfortable rotoblading independently, if you can't read an IVUS, if you don't know how to do ultrasound guided access of a groin, if you don't know how to put an impella in comfortably, then you can't do your job. Now, that's not your fault. That is your attending's fault, because your attending clearly doesn't know how to do their job, and they need to go back to training so that they can teach you to do your job well. And again, this effectively affects outcomes. That most of the people who do our job are general cardiologists that do PCI as a side note. And it affects the outcomes of people. I know it's controversial. Nobody likes it, especially the people that do low volume. They get very upset and very frustrated with me. I'm sorry. You're supposed to look at data and accept what data is. But we have a tremendous amount of cognitive dissonance in our profession, which when confronted with data we don't like, we change our narrative. We change our approach. The data is the data. And again, we put people, just like my friend who had a STEMI, less likely to use radial, a lot more contrast, worse outcomes. And that leads to care variability in what I do, which is CTOs. So the indication for CTOs is the same for everybody who gets cath. What's even more interesting is 20% of people without a bypass who get an angiogram have a CTO. 54% if you've had a CABG. What's also interesting is in the US, Canada, and Europe, 3 different registries, the biggest predictor that you go to bypass surgery on multivariate analysis, and this includes left main, 3-vessel disease, diabetes, LV dysfunction, or the presence of a CTO. Okay, CTOs should be fixed. We shouldn't treat them. They don't count. There's no value in it. Biggest predictor you go to surgery is the presence of a CTO. In syntax, the biggest predictor you went to the surgical registry was the presence of a CTO. That's cognitive dissonance, and it's academic inconsistency. It shouldn't pan out if I don't think it should get done, but it does. So again, going back to the theme in our profession, this would be from Silicon Valley. It's an innovation adoption cycle. Those who do will try to figure out a way. They will fail. They will learn from failure. They'll confront their aggressors. They will keep working, and they will find a solution. They're the innovators. Once they have had all the bloodied backs and the knife in the back, and they've been beaten up and abused, the next group of people will come in called the early adopters. And then over time, and eventually you'll have the laggards. And in healthcare, the laggards never actually do it. Even though it's a class 1 indication on the guidelines, 40% of patients don't get a class 1 indicated event, which leads us a little bit to another sort of change of pace here. That's my boat. Let's think about why people have angina. Okay. Myocardial oxygen demand outstrips delivery. I hate to tell you this, but myocytes are really stupid. They just know either I got enough oxygen or I don't. If you have aortic stenosis with really high wall tension, you have angina. If you have a hemoglobin of 4, you have angina. If you have a 50% FFR positive lesion, you have angina. If you have a 95% focal lesion, you have angina. If you have a 1 millimeter CTO, you have angina. If you have a 10 millimeter CTO, you have angina. If you have an 80 millimeter CTO, you have angina. If you have an 80 millimeter CTO with a vein graft with a tight lesion focally in its mid portion, you have angina. If you have an 80 millimeter CTO with a diffusely diseased thrombotic vein graft of the PDA, you have angina. The physiology of stable disease is the same in every one of those people. But we're going to treat every one of them different, not because of physiology, because of anatomy. And how much of the decision treatment of the anatomy is based on the ability of the person who does the angiogram. And is that the right way to make these decisions? And how do we do trials when that biases the outcome because we sort of cherry pick what we do? So the guidelines have never been validated, but the appropriate use criteria have, right? And for everybody out there, do you think the appropriate use criteria guideline committee was a bunch of very cowboy, cowgirl, aggressive, everybody should get bypass surgery and stent? Or do you think it's a pretty conservative group? The usual response is it's a pretty conservative group. Okay, so let's see how they did. They looked at all this, they had a committee, they got together, and up in Canada, they have the ability to track the disease, not the procedures. So they looked at everybody who got an angiogram, and they looked at the appropriateness, basically when you got your angiogram, and then looked at what therapies they got. So this is now called rarely appropriate. So about 40%, 45% of the people with a rarely appropriate indication either got a stent or got a bypass surgery. Now that number probably should be like 5%, but it's 40. Okay, we'll see what happens with them. And then when we get to uncertain, about half of the people with an uncertain indication get medical therapy. Now, the one that I'm more interested in is, here's green means go. The appropriate use people tell you, you should revasc this person or you're not doing the job. 32% get medical therapy. Is that an indication issue? Or is that an ability issue? Okay. And let's look at the outcomes. So rarely appropriate, you're way better off not getting a stent or bypass than getting it. These are 3-year hard endpoints, death and MI. Okay. Now, what's interesting, if you are uncertain and you get revasc, you do way better than if you get medical therapy. And the same is true for appropriate patients. So we had lots of review of this, and please don't stent people who are rarely appropriate. I'm fine with that. John Spurtis is a good friend, so is Paul Chan. I absolutely agree with him. You know, the joke we have in the US is there's the right number of stents being put in, just in the wrong patients. Because what we're avoiding are these. And it's not because it's not indicated, it's because we don't know how to do it. And that is on us to look in the mirror and stop saying we shouldn't and start saying, how do I learn? How do I improve? And you can show this again in the acuity trial. So if you know a syntax score is a marker of disease, the higher the syntax score, the more opportunity to fix disease. But what do interventionalists do? The higher the syntax score, the lower we do. So this would be called an interventional risk treatment paradox. What it says is, as the going gets tough, we run away. So what's that going to mean? It means likely if you've got challenging anatomy and you go to an interventional cardiologist, you're going to end up not getting helped. We'll say we put a stent in you, but the reality is we're not going to help you. And for self-reflection of any of you out there who actually want to look at getting better, what do we tend to say no to those uncertain and appropriate? Well, it tends to be people with calcified lesions, CTOs, bifurcations, aortic ostial, long lesions, and small vessel. And first, that's a whole nother discussion. But these are the options to look at yourself in the mirror and say, how do I get better at each of these lesion subsets so that residual syntax score goes down? Now, does that matter? Well, if you do an intervention or bypass surgery or put somebody on medical therapy and you leave their coronaries alone and leave them with a residual syntax score over 8, which is basically single vessel disease, you're actually doing harm. That's mortality in a year. That's not a soft endpoint. That's not TVR. That's death. Okay? So really, when I look at a patient and I have to do my job, my goal is to make the residual syntax score under 4. 8's good, under 4 to me is better. But do you do that? And if you don't, what are the lesions you're not doing? And what excuses are you making to yourself and to others to not do them? And again, when you look at completeness of revascularization, this was syntax, not looking at whether it was bypass surgery or stent, just complete versus incomplete. Shockingly, you're born with 3 open arteries, and if you have 3 open arteries without a lot of ischemia, you do well. This is New York database. It's a busy slide, but basically says the same thing. If you leave lesions, you leave more disease, your outcome is worse. These are mortality rates, hard endpoints. Okay? So why are you choosing not to treat it? Again, same kind of thing. So here's the real issue. The reason bypass surgery is better than us is bypass surgery is a simpler therapy than doing PCI. Because for a surgeon, it's the same every time because the anatomy doesn't matter. You basically open the chest, you put on pump, you sew proximal, you sew distal, you sew everything up, you declamp, you de-air, and you restart the heart, and everybody's grand. But what they're sewing into is technically, effectively, almost the same every time. Interventional cardiologists, we've learned how to put a wire balloon and stent down a vessel. Well, that's great when it's easy, but what if it's tortuous? What if it's calcified? What if they have LV dysfunction? What if it's a CTO? Where in your training did you learn how to do that? Where are your current interventional fellows going to learn those skill sets if you didn't know how to do it? And so we just don't do our job very well. Now, lots of people get really upset with me when I bring this up. This isn't personal. This is what the data shows. This is what you see when we watch people work. It shouldn't upset you other than, how do I improve? And the goal is not, I need you to be the best interventional cardiologist on earth. I don't even know what that looks like. The goal is, how good can you be? How much better are you at treating anatomy now than 5 years ago? Or really what you're better at is saying, no, I can't do that, so that shouldn't get done. What you're really good is acts of omission. If I just take that patient who's appropriate and send them home, when they die, it's not in front of me. Rather than, yeah, but if I have to learn to do those lesions I don't know how to do, I'm going to have to show people that I'm not very good at my job because I'm going to fail. I'm going to have to ask for help. I'm going to have to find help because it's probably not in my own center or we'd already be doing it. I'm going to have complications and I'm going to get critiqued for my complications. Valley of despair. We're going to make a lot of reasons why you can't do it, rather than how do we as a group help each other to improve our technical skill sets so that we can improve the outcomes of our patients. I'm going to end with 2 trials to show some differences. So I'll start with ischemia, and everybody's going to get mad because I'm actually not going to show you the outcome of ischemia. And the reason I won't is, as a trialist, ischemia is a 0 trial. And this is where everybody will get mad. So I look forward, realize I've had this discussion with Judy Hockman and Bill Bowden. So I'm happy to take questions on it. So the whole idea is basically what I just said. I believe in complete revasc. If you have an ischemia causing lesion and I revasc it, people will do better. Totally agree. Absolutely positively, I believe in that 1,000%. Did ischemia do that? So again, in stable patients with moderate ischemia, is there a benefit to cath and revascularization compared to medical therapy? So you have coronary disease. Should we fix it? And if we, or just leave you on medicines, right? Very simple. Okay. Everybody's seen the study design, all the good stuff. So I want to talk about one interesting thing about trials. So let's talk a little bit about selection bias. NYU, which is where Dr. Hockman resides, and it's her colleagues, does 1,700 PCIs and 600 cabbages a year. That's a lot, right? So here's a trial that's we're going to apply this to everybody. It's going to change the world. In 7 years, they enrolled 37 patients. So if 0.001% of the patients at NYU got enrolled in ischemia, how applicable is that to what we do? Or as everybody basically said up front, basically the only people we're going to put in this trial are people we don't think need it in the first place. Well, then you've biased it to a lower event rate group of people, and you're going to have enrollment issues. So does anybody even care? How applicable is it? We looked at the endpoints, but I want to bring up a little bit more. Again, if you look at a SAC of 80 is actually not very symptomatic. A lot of asymptomatic people. So how applicable is this? Because most people we cath have symptoms. But I also want to bring this up because I was a heart failure doctor and we had to do trials of people with LV dysfunction. Now, in ischemia, 20% of people in the invasive arm got no revascularization. That's because 2/3 of them had no disease. So is there another trial of any therapy ever done on earth where 15% of people enrolled, because you got to assume it's probably the same in the medical therapy arm, didn't have the disease that we were going to study our therapy to improve the outcome? I mean, if I was doing a beta blocker trial in heart failure with, you had to have an EF less than 40, and 15% of the people in the trial had an EF of 55, one, which way is that going to bias my outcome to? The active therapy or the placebo? Well, the placebo. The other is, what publication or meeting would accept that as rational approach to what we're doing? So my only comment on ischemia is it's not a valid trial because 15% of the people had a disease, didn't have a disease you were trying to prove the outcome of, which explains why all the event rates and all this other stuff. But we can't look at that and say it's a great trial. We shouldn't laud it as this amazing thing. It's embarrassing. I mean, I think the other piece that's embarrassing is 6% of people in the trial had unrevascularizable coronary disease. I think that's an embarrassment on the interventionalist because that's clearly not true. Now, what I want to lead to, hopefully for the people in the room, is, yeah, so that's hard to look at. And a lot of people are going to tell me, oh, Bill, you're crazy, or you're being rude, or you're not being thoughtful. I'm sorry you don't like it. It is what it is. And that's okay. We can choose to disagree, and we can still be friends. We don't have to hate each other. So my wife, at age 43, decided she was going to go out and run 2 marathons, one to qualify for Boston and one to run Boston. And I put this up to remind me that it doesn't matter where you are in your life. If you decide to do something that you want to get better, you'll go out and do it. And that's what my wife did. Unfortunately, that happens to be the day before the bomb went off in 2013. Fortunately, she is very fast, and we were back at the hotel when the bombs went off. So Syntax 2 is an interesting trial. What they basically did is they took the Syntax sites and cherry-picked them. And they've cherry-picked the sites for operators that could do 3 things well. They could do physiology well, they could do image-guided PCI well, and they could do complete revasc well. And then they looked at patients, and that's what they did. They did physiology-guided PCI, and 1/3 of the vessels that they looked at with physiology went away. So realize potentially 1/3 of the LADs you send for bypass surgery were physiologically negative. So I would tell you is before you send somebody to a cabbage, you better make damn sure that left main LAD is physiologically significant, or you just wasted the procedure. And did you send them for that 70% LAD because they also happen to have an RCA CTO, which you don't want to deal with? Okay. The second is they had a pretty good success rate in CTOs, almost 90%, which is about what a true program should have in people who've never had a bypass. Should be in the high 90s or high 80s to low 90s, depending on what you want to learn. And what they looked at is, compared to PCI, if you do image-guided PCI, physiology-guided, and complete revasc, your hard endpoint outcome looks a lot better. Matter of fact, it looks a lot like surgery. So is it really stent versus bypass, or is it really doing PCI at a high level gives patients a better outcome? This is, again, just looking at all the different endpoints, which are dramatically improved if you do image-guided PCI, which we know. But despite that, only 13% of the procedures in the US are done with image guidance. That's pretty sad. and with complete revasc. So there you go. So I'm going to end with a couple of things here, and then I can get some questions. Which failure is never fatal, but failure to change can and might be. So for everybody in the room, do you want to argue or do you want to try and change and learn? And the real question for the interventionalist is, you don't have the time to do it right. When are you going to have the time to do it over? Realize image-guided PCI reduces restenosis rates 40%. 40%. And for everybody, as you learn, as you go off on your careers and you want to get better and you develop the curiosity to figure out why are others doing it differently than us? Why are others able to do things we can't? Why do we make the decisions we make? Basically, failing to prepare is preparing to fail. So be curious. Learn. Ask why. Be able to defend the why. And if you don't know, be humble and find smart people and see if they can help you figure out why we need to do what we do. So I will leave it with just, I think that there's a lot of variability in therapeutic procedures. I've discussed a lot about coronaries, but we could do the same thing talking about TAVR, mitral, AFib ablation, VT ablation, and any endovascular procedure that's done, especially in chronic limb ischemia. I think, unfortunately, being in a medicine specialty of a therapeutic specialty challenges the outcomes of our procedures, and the ability of our operators definitely affects both the selection of patients into trials and the quality of the procedures being done in those trials. I didn't go into this a lot today, but the fear of complications as people critique you, potentially attack you, potentially threaten your ability to do your job, limits technical growth and development. And it's a culture that needs to be changed. And if you're more interested in understanding that and learning from that, we run a complications only course here in Seattle. It's July 14th and 15th. And it's 2 days on nothing but the psychology and technical management of a variety of procedural complications that occur in the cath lab. That's my email and cell phone. If anybody ever has questions about how to get better, or the reading that needs to be done, or ways that we can make our profession and therefore our patient care improve, I'd be happy to talk to you. Thank you very much for having me, and I'm open to any questions.
Thanks so much, Dr. Lombardi. That was such a sobering and at the same time very inspiring talk. So yeah, if anyone has questions from the audience, please either type it in the chat box or raise your hand so we can call on you. One question I had is, you talked a lot about really pushing your existing knowledge base and developing and being curious about getting better with technical skills, especially when there's new innovation always coming out. And so my question is, how do you know your limit? And also, how do you deal with the fact that when you're trying something new, especially when you're an attending and maybe the most experienced person in the room, there is someone's life on the other end. And there's always that risk associated with learning of having complications as you're trying to learn.
Yeah, I think that unfortunately what you have to realize is we don't have good simulation and good models. And for me, what I do is I work in other centers and I have other people come and work with me. And that helps me to learn. And it helps me to try and push the envelope as safely as I can. It's the same thing we've had to do with, Jamie McCabe helped develop Basilica and Lampoon and Sesame, and all of those procedures. We had to be very careful. What we tend to use is you have to be a conscientious cowboy or cowgirl, which is you want to make sure that the whole team thinks, okay, we need to do this. We need to learn to do it. We also understand is unfortunately something bad might happen when we do it. But it goes back to is something bad's also going to happen if we don't. It's just easier emotionally to have the don't because it's not in front of you. And that's the way I look at this is if you don't learn these new things, it'll make you feel a lot more comfortable, but you're going to end up harming a lot more patients. And so it goes back to the culture is I can't just go in and I just did this high-end retrograde in a post-CABG patient, sticking an Estado into the aorta blindly and all this crazy stuff. I can't just sit there and say, hey, I'm going to go do this because it's an appropriate indication. What I have to do is I have to teach all my cath lab staff, this is why we're doing it. This is the reason behind it. I need to teach all my interventional colleagues, hey, this is what we're doing. These are the potential bad things that are going to happen. So a lot of times, Jamie and I, or Kate and I, will scrub with each other saying, okay, we need to be able to manage the risks. You're better at this. I'm better at this. We're going to get together. And you know what? We tell the patient something bad may happen, but something bad is going to happen if we don't. And it's your choice. So we have a very open consent. Our biggest referral is actually from our heart failure transplant program, both the surgeons and the docs, because they know we're not just a bunch of cowboys stenting any lesion we can stent or doing a TAVR on anybody who happens to have mild AS. We think long and hard about why are we doing it? Is everybody on board with it? And how have we managed the risk? And even if we manage the risk beautifully, bad things can happen. Surgeons say no. I bet everybody at UCSF has a surgeon who's their go-to surgeon for something because they know they'll probably say yes. But I also bet you money that person's complication rate is higher. And what they've done is they've emotionally been able to say, yeah, I know mitral valve replacement has a 6% mortality, but I'm okay because it needs to get done, but I've got to live with that. And we don't do that well in our specialty of understanding the emotional toll that happens when bad events occur. And that's one of the things I'm trying to work at globally as a mentor is we need to be more discussing the impact and the emotional toll that complications have on us and how it affects our ability to actually get better. And that's a cultural change that we need to fix if we're actually going to be able to do what you just asked, do these higher risk procedures more successfully over time and to learn from them.
Thank you.
Dr. Elmira?
Yes, hi, Bill. Thank you so much for joining us. I mean, it's great to have you, and it's a very thought-provoking talk with several points that I want to touch on a couple of them and really get your thoughts on it. I mean, certainly we both come from institutions that are have highly competent cath labs that are able to do and have people that are specialized in CHIP and CTO and complex, not only coronary, but structural procedures. But you started off your talk focusing on things that are really a bit more basic and fundamental, and they're really essentially good clinical practice and intervention. So namely radial access and image-guided PCI. We are at sites where those things are very widely adopted, but we're doing a very bad job, I think, in regards to promoting adoption of optimal and best practices in the community. And you, of course, gave a very insightful example of that with your colleague who had the STEMI. How do we as a community, as an interventional community, actually promote the adoption of best practices outside of our centers so that things like that do not happen?
It's a great question. I would tell you it's not about promoting it. Everybody knows it. It's why aren't they adopting it? And the reason they're not adopting it is because nobody's being held accountable to doing it. I can tell you right now, 90% of the interventional fellowships don't train people how to do image guidance. If you want to start with, it's not just in the community, it's in the academic interventional programs. You know, I know somebody went to Texas Heart, he did 600 PCIs, doesn't know how to read an IVUS, doesn't know how to use a microcatheter, barely knows how to use a gut extension, and basically left to go do peripheral intervention because he's going to do coronaries as a sidekick. We have to hold ourselves accountable, and we don't. And that means SCI and ACC have to hold people accountable, but those are political organizations. They're not patient-centric organizations. They're financial institutions. So I don't know how to solve the problem other than to try to continually point out that you can learn simple things. The question is, do you want to? At some point, governing bodies or state regulators will need to hold people accountable, or we'll continue to have the variability that we have. But I don't think this is about promoting. You can get on the internet and know all this stuff. This isn't about, you know, I just took my boards. I mean, the boards are criminal. They don't teach you how to be a good interventionalist. They don't discuss any of this. They don't hold you accountable to it. Matter of fact, you have to be dumber to take your boards and actually do your job. So I would just tell you, I think, Sammy, I think that we need to do a revolution, but that revolution is to go at Sky, go at our leadership and tell them to hold people accountable. And until we do that, this is probably not going to change. And I would tell you, I think the people that should be held most accountable are the academic interventional programs, because they're the ones training people who are coming out and doing the wrong thing.
If I can just build on that a little bit, I mean, the other aspect of what you're saying, you really built a culture, it sounds like, at UW for innovation and for really pushing the envelope. And you have done it through, of course, your very intense focus on the coronary side. I know Jamie's doing nearly 500, 600 structural procedures. And so he's, of course, intently focused on the structural side. But how do you manage at what point do you give up the other? And what I mean by that is, at what point are you a structural person and do you take your hands away from the coronary interventions and vice versa?
I think that's a challenging discussion. I would put it this way. I had a podcast with Manos Berlakis, and one of the things that came up was this question. I just said, you can't be great at everything. And so the hardest thing for most of us, we've been trained to be Marcus Welby, MD. Well, of course, I know everything about everything. That's not true. And as you get into technical things, right, it's very few people have been NFL football players and baseball players, right? Just different skill sets. So the real issue that we need to do is, instead of supplying so many people who can't get jobs so they go get low volume jobs, is when do we actually say, instead of one person building the whole car, when do we say, I need you to do this well, I need you to do that well, I need you to do that well. But to do that successfully, you as a person have to say, even though I can, I'm going to choose not to, because I want to help the person get a better opportunity. It took a long time to get Jamie to basically not do CTOs, because he wanted to be able to do everything. I talked to Mark recently about that. I tried to get Mark to go to the podium and say he doesn't do coronaries, because he wasn't, and just admit it. Because somebody has to mentor it, somebody has to model it. And I think that the timing of that is very challenging. But I do think at some point you have to admit, I can't be great at everything. So as a program, my job is to allow someone else to do something, to let them be great. I'm going to focus on what I'm great, and we're going to make sure that we help each other be better than the parts. And I think that's, we have a profession where you are the greatest at everything, right? I am the greatest of everything. To change that narrative to, they're great, I'm great, together we're better, is part of the culture change that we need to work on to be successful.
I think that was beautifully stated. Thank you, Bill.
There was a question we had also from Dr. Desjardins, who's one of my co-fellows, speaking on the variability across training programs. Are there any thoughts you have about changes to be made, kind of systematically across interventional training programs? For example, should there be a basic competency or, set of requirements that the program should abide by and qualify for before becoming a program? You mentioned, for example, having a low percentage of people feeling comfortable and competent in image-guided interventions. And so should those current standards that exist be modified in any way?
Absolutely, 1,000%. I went to the president of Sky with an outline of what I thought we should hold training programs accountable to. After they critiqued that CHIP seemed elitist. And I said, it's not elitist, it's what coronary interventionists should be able to do. And I was flatly told, no, they won't support that and they won't do it. If you go to ACGME, who supposedly regulate this field, all they care about is you have a diversity program in place, and they don't actually even check your volumes to see if you're meeting any volume requirement, let alone the type of procedures being done. again, I think as a fellow, you guys should be screaming at ACGME, and you should be screaming at SCI and ACC, your leaders, to say we need to have programs that allow us to be better, not just I get to do the job because I did a fellowship. I think it's very disappointing. I'm not a very good politician. As you see me handling this talk, these are challenging discussions. I tend to get a little too emotional. Historically, I've been very binary and I think the word people usually say about me is I'm very polarizing. And that makes it difficult to have these sort of political type discussions. But I do think that as a group, we need to start asking our systems to hold us accountable and to hold the people teaching us accountable to a more clinically useful set of skills to do our jobs well for patients, which is the most important aspect of this.
Definitely. And then Dr. Alexis Beatty had a question as well, which was just, could you describe the interventional cardiology experience at UW and the complex disease and cases that are seen as a trainee there?
Yeah, we're an interesting program. So we don't have a general cardiology program because of a variety of historical issues. So we do about 750 diagnostic angiograms on our campus, and about over half of those are in heart transplant patients. So we have about 350 caths. So we don't get to see a lot of what most people would consider a normal intervention. Like I said, before I got to the U, they were doing 250 PCIs a year. We now do 1,000 with no change in our cath line. And effectively, our volume is all turned down by surgery, ischemic cardiomyopathy turned down by surgery, turned down by interventionalists, or a patient who found us because they've been told it can't be done, and we will. And so our first-year interventional fellows, actually, it's very hard because when they start, like actually the last 5 years running, the first intervention done by our first year was an unprotected distal left main. That's a type A lesion at the U. And so the learning curve is very steep, but we do about 170 atherectomy cases a year. So they're each going to get 50 atherectomy cases as the front operator. We tend to, especially this time of year, most of us are not in the cath lab when they're doing it. We're in the control rooms on a headset, letting people do it hands-on. So we have a very steep learning curve, a very I don't like the word complex. We have a very high-risk anatomic subset. Again, we do about 175 atherectomy cases, both rotational, orbital, and laser. We do about 400 CTOs as a program a year. We do a lot of no contrast PCI and a lot of ischemic cardiomyopathy because we do about 75 transplants a year. So we have a very big heart failure program. So we do a lot of these, and it's the fellows that train here don't realize that this is not normal. And also that when they get out, what they've been doing is bread and butter is actually the highest risk case that the lab they're going to go work in does. So it's, and the same with the structural. I mean, there's not a lot of structural programs where you're going to learn as a fellow to do MitraClip, paravalvular leak closure, Sesame, Lampoon. I guess Jamie's calling it clave, which is using a MitraClip to abut a TMVR, Basilica, TAVR, and all the other, and then PERC Ax, PERC carotid, and PERC transcable access. So what we don't do well here is peripheral. If you know anybody who wants to be an academic CLI operator, we're looking for one. We'd love it.
Thank you. That's amazing. Any other questions we have from members in the audience?
Isn't Shunk going to say hi to me?
I saw he joined.
He's there.
Hey, Bill.
Hey, Rick. How are you, man?
Hey, can you hear me okay? Yeah, sorry, I just got here really late, but it sounds like it was a great discussion. And I'm really impressed to hear, your summary there of what's going on at University of Washington. It's amazing. And I'll have to go back and look at the video.
Yeah,
It's recorded, right?
Yeah, I think one of the fun things that I've gotten to do here that I really have enjoyed is we got our institution to let us get 2 pathways to have outside physicians come work with us. So we have observation privileges, which takes about 3 weeks to get. And actually, we can get people hands-on privileges to scrub with us. And so probably about 26 to 30 weeks a year, we have people from around the globe coming to our lab and spending time with us. And it's a great way for us to sort of coach and update ourselves because we get to talk about challenges. One of the things I do a lot of talk about is purposeful practice, which is, don't try and do 47 things. It's like, okay, what are you struggling with right now? Let's find the lesion subset you're having the most difficulty with. And then let's talk about how do we purposely practice the skill sets to eventually deal with that anatomic subset. And, I think it's been great for our fellows because they get to meet a lot of people. They get to see a lot of different perspectives. It's great for Kate and Lorenzo and I, because again, we get to be challenged as to, are we doing the right thing? And also people tend to bring some tip or trick or a thought in that allows us to, again, stay innovative and current. And I think that's a really important thing is silos tend to be really dangerous. And so if you've not been out of your lab and worked in another lab, I really encourage you to go do that. It's a great way to learn. The meetings are nice, but they're very artificial. And people in live cases tend to not be quite as authentic as they might be if you just saw them doing their daily work. And I think that's really where you tend to grow and get better.
I totally agree with that. And there are a lot of obstacles to that at various institutions. And it's amazing that you've been able to overcome those. Because, you learn so much when people come proctor or when you go to other labs, things like that. It's really a priceless experience. And so, I'll hit you up separately, try to get up and see you again.
Well, yeah, I'll have to put you email me, Rick, because there's after the complications course, the following Monday, Tuesday.
Yeah.
I've got a little private CTO event for about 50, 60 people from around the globe. You probably should try to sneak up to that.
Oh, okay. Sounds great.
So email me and I'll hook you up.
Okay.
All right. Well, thanks so much again, Dr. Lombardi, for a fantastic talk. And for the folks in the audience, next week we have Dr. Joelle Salem from the Sorbonne speaking on myocarditis related to immune checkpoint inhibitors too. So I hope to see you there. And thanks everyone again. I hope you all have a great rest of your day.
Thanks everybody. Have a great one.